Thank you for the organizing committee, especially to Yolanda and all the patients involved in the Aniridia Association. Thank you for your attention. I will try to be clear and short about my presentation, how to treat or when to treat the cataract in congenital aniridia patients. Okay. So Rafael has shown to you which are the most common lens anomalies in congenital aniridia. It can affect its transparency, its position, and the shape or size. The cataract has an incidence in young patients between 50 to 85%, and you will have, as he has shown, several morphologies: anterior, posterior subcapsular, etc. So you will see same pictures he has shown. And then the decision is when to do the surgery and how to do the surgery. This is very important for these patients, which not only they have cataracts, they have also other problems like hypoplasia. For example, this case with a partial aniridia, in this case we are very lucky because we can repair the iris. I will show this technique in which are going to do a cataract surgery. It's very important to examine the zonular ligament when doing the cataract with the viscoelastic or touching the lens if there is any kind of a zonular weakness. Then what we are going to do first is to remove this membrane, which is making the iris rigid. This is a small membrane which is attached and will allow us to make a suture of this tissue. When this white strand is removed, then we will do the standard 2.2 incision to make the aspiration of the cataract. Then we will open the anterior capsule in a maneuver which is called capsulorhexis. For those which are not surgeons here, we'll do this round opening, and we are going to remove with a device which is called a phacoemulsificator. It's a tube which is irrigating fluid, and also with ultrasounds you can aspirate the cataract. All these maneuvers must be performed very carefully because the zonula in these patients usually are very weak, all this ligament. Then we will dissect the lens material, the lens cortical material, and with the phaco tip. Then we will aspirate. This case is a little bit hard, so we have to do a small groove in the middle. And with this two-hand chop technique, we will break the nucleus of the lens into pieces, and we will aspirate then. This is a standard cataract for a cataract surgeon, but the thing is how to repair the iris, which is not a common situation in patients with aniridia. Most of them, they don't have any iris remnant, so in those cases we don't have the possibility to suture the iris. Here you see how we are breaking, working in the middle of the lens, and aspirating all the material until it's clean. Then we will put a lens which will be located in the capsular bag. We clean the cortical remnants, and then when it's completely clean, we will place the lens. As I have told you, it's very important to preserve the stability of the back, because if we have to suture lenses or we have put lenses in the sulcus in this kind of patients, that they can induce an inflammatory response, which is more more aggressive than in normal patients. So this lens is located inside the capsular bag, and then we are going to proceed to examine the stiffness of the iris. In this case is soft, and then we decide that we are going to proceed to suture the tissue, to reconstruct as much as we can the iris diaphragm. So this procedure is done by a needle. It's a long curved shaped needle in which we are going to pass through both borders of the pupil, and then with several techniques which are described in the literature, we can close the knots and make the pupil smaller. So it will benefit the patient having a less sized pupil. So we are closing the remnant hole, which can give some symptoms to the patient, which is inferior, and then the iris is repaired. In this case, we were lucky, but in other cases, we are not. So for me, the most important questions that we have to think as a surgeons, when to operate a patient with corneal aniridia and how to operate the patient. We have different techniques, and also as a surgeons, we have to know, despite we have very few cases to operate cataracts, we have very few cases with patients with congenital aniridia, we have to think if there are specific, and we have to know them, if there are specific complications of cataract surgery in patients with congenital aniridia, which the answer is yes. So we have to take in account which is the age of the patient. Do we know really his or her maximum potential visual acuity? So it is worth it to operate the cataract. How is the optic nerve? How are the visual field tests, if there is a glaucoma or not? Is there loss of vision due to the cataract or not? And how is the ocular surface and the intraocular pressure? So there are cases in which, like this, in the left side, with this small nuclear cataract, this patient is a young patient, probably, it has no limbal deficiency, visible limbal deficiency yet. So in this case, the answer is no. In other cases with dense cataracts, white cataracts, the answer is yes. So which technique? Extracapsular extraction with large incisions, small incision with a standard phacoemulsification, and the use of iris prosthesis. Those are questions that we have to make an individual decision in any patient. If we are going to implant a diaphragm lens like the Morcher lens, that now they are not available, but when we did it, we have to do an extracapsular insection and a large incision to implant the lens. Which this large incision affect the limbal deficiency? Probably. In my opinion, if we can, we have to use the small incision standard phacoemulsification. And we have to avoid the use of iris prosthesis in this kind of patients, specifically in aniridia. These are old lenses because they are not in the market anymore because of the seeing problems. And we have this kind of rings to use, but like this, and also the Reper, which comes from Russia, which can induce also an inflammatory reaction in these patients and in other patients, and also this kind of iris of human optic. These are the several prostheses that we can use, and it is very attractive to restore the iris and restore everything, but we have to know what will happen in the future in most of the cases. No? We have cases like this, operated maybe 10 or 15 years ago with very good tolerance of the prosthesis inside, with a very good result. This is a result with two different prostheses placed to make a new pupil, and this is a lens placed in the back without any kind of prosthesis. There are many people that are looking for these prostheses, but we have to know that the more hardware we place inside the eye, the more complications rate we can have. So if the patients have glaucoma, it can worsen. The glaucoma can be induced for these prostheses, for these plastic tissues inside the eye. We also have to know how is the zonula, because it can, if it's very weak, it can dislocate. And also we have to know that in aniridia patients we have this progressive anterior fibrosis syndrome, which is much more common in children and young adults. And it's the presence of endoprosthesis can favor its appearance and worsens visual prognosis. You have, for example, this case that was, I don't see it well, but it has a lens in the back with a tension ring that has dislocated completely superiorly. So this patient has a complication, and we have to solve these complications in this kind of eye. You see here perfectly, the lens and all the back is dislocated. Patients that after a cataract surgery, they end up with a corneal transplant, with an anterior fibrosis, and end up in this horrible situation. So my recommendations to end my presentation is to operate these patients only when they need to be operated, because many times the vision is not affected for cataracts that affects only the surgeon in the slit lamp. We have to evaluate in the pre-op the presence or the risk of glaucoma that a cataract surgery can worsen. How is the ocular surface status? All the incisions can affect the ocular surface. And how is the zonular ligament and the crystalline lens? Now we have better techniques to fixate lenses if we have problems in the zonula with less plastic materials inside the eye, like Canabrava technique, or because suturing a lens, in my opinion, in these cases should not be done. And always use the less aggressive technique. We have to take care with diaphragm IOLs, only indicate in very quiet eyes or very, not young patients, old patients can be, this kind of lenses or endoprosthesis can be suitable, and always avoid its contact with iris remnants, anterior chamber angle, sulcus, and ciliary body. Thank you very much for your attention.